Good evening. My name is Dr. Jonathan Nicozisis from Princeton, New Jersey, and tonight the topic of my webinar will be using manual osteo-perforations and high-frequency vibrations to help facilitate orthodontic tooth movement. By way of disclosure and introduction, I am not employed by any dental company. I do own some securities in Align Technology in my retirement account. That is my level of interest in any of the companies you hear about this evening. No family members, immediate or extended, are employed by or own any of the stocks or securities in any dental companies that you may hear about this evening. I have in the past and currently do consult and evaluate products for both Propel as well as Align Technology. I've been compensated for this webinar and as well as past stuff being evaluated, including Propel Orthodontics. My participation in this event, I have received an honorarium for. The opinions in this presentation you're about to hear are my views alone and may not necessarily reflect the sponsor's views, that being Propel. The materials provided are for educational purposes and not to be used for any advertising or endorsement purposes. This presentation has been approved for continuing education credits. No recording, photographs, video, or audio are permitted during the presentation. I will skip my background because for those of you who know me know that I've been in practice for about 17 years, but I've been had the good fortune of speaking for Align Technology and Propel, and even most recently 2 years ago co-authored the textbook chapter with Align's Director of Research and Development and my mentor, Dr. Orhan Tunjai. And so by way of introduction, I'd like to kind of frame the conversation of this evening, and that is what I have termed the fourth order of orthodontics. And by that I mean osteo-perforations and this facilitating technology with high-frequency vibrations is our ability as orthodontic specialists to augment the patient's biology for our own benefit as well as the patient's own benefit. So instead of getting down in the quagmire of discussing first, second, and third order movements in orthodontics, you know, torque in the base of the bracket versus torque in the face, etc., I'd like to zoom out and look at the biology of the alveolar process and trying to augment that to our advantage. So again, this is termed the fourth order of orthodontics, and keep this perspective throughout this evening's webinar. So when it comes to accelerated orthodontics, there's certainly some benefits that are very tangible. There's fewer office visits, and that means less time off of work or away from school for your patients. Certainly reduced patient burnout because treatment potentially takes a heck of a lot shorter amount of time. And because it's a shorter amount of time, there is potential for reduced hygiene issues. And I like to call this the orthodontic vortex. In the Northeast here, over the last several winters, we've had plunging temperatures during the winter time, and they call it the polar vortex. We had a whole month worth of freezing temperatures. The highs are well below freezing. And so with plunging temperatures, this made me think of the orthodontic vortex and the plunging number of office visits for us to complete a patient's case. And as such, there's an inverse increase in the profitability per visit. And so you're here this evening to learn about this technology today. So when you combine reduced visits per case, increased profitability per visit, and doing so with Invisalign, meaning no braces, for me in Central New Jersey, it is a marketing strategy unlike anything ever before in our industry, and I am killing it in Central New Jersey. Pairing Invisalign, clear aligner therapy, and osteo-perforations, high-frequency vibrations, I have chosen to use the Propel system towards this endeavor. And you're here today to embrace this technology and make your practice stand out in your area. It's about developing unique capabilities, distinct capabilities that are unique to you in your area to make your practice stand out, to attract people that would not normally seek treatment otherwise. Case in point, case number 1, second opinion, came to me from the doctor locator, went to my website to learn more about me, found my information on Propel and osteo-perforations, and came in. And so here is David, class 1 malocclusion. This is low-hanging fruit walking into your office. So as you look at this case, think about how long this might take for you to treat with braces or Invisalign or otherwise, lingual, whatever the heck you'd like to do. And so here he is at stage 12, stage 18, and at 18 I did some enameloplasty to get some of the incisal edges, and of course hindsight's always 20/20, and a couple things in my ClinCheck that I would change. For instance, I did not have my sash attachment on tooth number 10 to help assist in the rotation of the distal in. And I should have applied a little more labial root torque, but I got from here to here in 5 months with 2 Propel osteo-perforations treatments, and we're going to discuss this case at length later. So in refinement, I have my sash attachment to rotate that distal in, and I am done with David in 7.5 months. This is powerful. This is unique. This allows me to stand out and market myself unlike any other technologies I've had in my 17-year career. And so from there to there in 7.5 months, but going back, you can see the improvement in the refinement with that rotation, as well as the labial root torque on tooth number 26. And so what? What's the big fat deal? Well, let's look at it and how I treated this case. First exam records, consult, scan and start in 45 minutes. That was with the old scanner. Now with the iTero element scanner, this whole same day start is down to about 35-40 minutes to me. Second visit, I bonded attachment, did Propel. That's a 30-minute visit, my practice. Third visit, Propel again. Fourth visit, remove attachments and scan for refinement. And you're going to see the difference between this case now and how I would handle it with high-frequency vibrations, because I have found that with high-frequency vibrations, I eliminate this second Propel treatment, osteo-perforations treatment, and we'll discuss this in one of the last cases. Then remove attachments, scan for refinement, bond attachments, give aligners. Seventh visit, give retainers. Okay, I treated this patient in 7 visits. Here's my fee. $6,500 for Invisalign plus $600 for Propel. My hard cost, my lab fee back then was $1,650 minus my rebate of $56,561 gets my aligners down to here. So let's look at my 2 Propel tips, about $110 in volume. Gets me to a fee of $220. Retainers at $100, miscellaneous costs at $100. My total hard costs for this case are $1,509. $1,509. So if you subtract that from my total fee, that is my net. Divide that over 7 visits. This includes initial visits as well as placement of retainers. So my profitability per visit is just under $800. If you remove the initial exam and the retainer delivery visit and focus simply on the visits responsible for tooth movement, I'm at 5 visits for this case, and my profitability per visit jumps to about $1,100 and change. So what? That's what. That is why you're here today, to embrace this technology. So before we continue with more case studies or case reviews, let's go to the science behind manual osteo-perforations. So we know in orthodontic tooth movement is indeed controlled trauma, and as such there is injury, there's bone injury. With injury there's inflammation. With inflammation there's cytokine release, interleukins 1 through whatever, all these secondary messengers you've forgotten about since residency. There is a decrease temporarily in bone density, and the net result is an increase in the rate of bone remodeling. And so there's a pressure and tension movement with orthodontic tooth movement, and on the tension side you get bone being laying down, osteoblasts, and on the pressure side you get osteoclasts to remove the bone, and there's vasoconstriction, and you get frontal resorption when there's nice easy forces as opposed to hard forces, which results in undermining resorption. And so if heavy forces are used, you get undermining resorption, and there's necrotic cell-free zone higher incidence of hyalinization. That's what these red marks are for, and it actually slows the rate of tooth movement down. So there's this whole cascade of events that are occurring, from osteoclasts, precursors, and differentiations to eventual pre-osteoblasts and osteoblasts to lay down new bone. And so there's all this whole cascade of secondary messenger proteins, interleukins, cytokine expressions that are important for all this to occur. And so studies coming out of New York University, and this was in the American Journal of Orthodontics, I believe in November of 2013, 3 years ago this month, and it discussed the effect of micro osteoperforations on the rate of tooth movement, and had 20 patients, the study that is, a single investigator, and they used a handheld appliance designed by Propel Orthodontics to create micro osteoperforations. And their clinical observation is that they witnessed and recorded a 2.3-fold increase in the velocity of canine retraction when using micro osteoperforations. And more as importantly, patients reported really no different in discomfort from the control side where perforations were done to the the control side where perforations were not done to the experimental side where perforations were completed. And currently there are studies going on now about the ideal frequency and the number of osteoperforations necessary related to specific types of tooth movement. And so here's a case showing on the right, time 0, B, time 24 hours later, and again on the right side of this patient, there was no perforations. On the left side, there were perforations. And C here shows 28 days later. And you can visually see, and these springs were calibrated, by the way, and you can see how there is indeed that much more visual movement occurred on the side where perforations were completed within a 4-week period. They then measured the cytokine expressions, these interleukins 1, and pay attention to this because you're going to see an expression of interleukins later using a different technology, which is new in the marketplace, and exciting stuff is going on with that. But we have, they measured the gingival crevicular fluid, and on the side where osteoperforations were performed, indeed there was an increase in all of these secondary messengers, which leads to more bone remodeling, faster bone remodeling, and hence faster tooth movement. And what it showed, this research also showed, is that the cytokine activity decreases very gradually over time. And so it's indicative, or indicated I should say, that you should repeat your osteoperforations procedure every 10, 12, 14 weeks, whatever it is that you deemed as necessary to maintain the stimulated and localized inflammatory response. So, and we also found from this research that the beauty is that this response from the site of the micro-osteoperforation radiates about 6 to 10 millimeters around each site. And so that is important whether you're doing one tooth or whether you're doing a whole quadrant in terms of the number of perforations, because you're getting this radiating effect. And as mentioned previously, patients reported really no difference in discomfort from the experimental side to the control side. And so that, I think, is a wonderful thing to report. And so this schematic shows that under normal orthodontic tooth movement, you get inflammatory markers released and expressed. But when osteoperforations are placed in the mix, that's what these 3 black holes are here, you get an actual increase in inflammatory markers, and that leads to an increase in what we know as osteoclastogenesis, or the generation, the precursors of cells that differentiate to become osteoclasts, so that more bone is removed quicker, and hence teeth move faster as the bone remodels. And so the conclusions from this study is that MOPS significantly increase the expression of cytokines known to recruit osteoclasts so that they can differentiate to osteoclasts to help remove the bone undergoing orthodontic tooth movement. MOPS increased the rate of canine retraction about 2.3-fold compared to the controlled side. Patients reported, again, only mild discomfort locally at days 14 and 28, and little to no pain was experienced. Point number 4, MOPS are effective, they are comfortable, and they are a safe procedure that is able to be repeated throughout treatment as deemed necessary from the doctor to accelerate and facilitate tooth movement during orthodontic treatment. And in this study, in the 28 days, it was shown that it could potentially reduce orthodontic treatment plan by about 62%. Personally, I find, since using it over the last 5 years, I see ranges anywhere from 30 to 50% and sometimes more. Ultimately, it depends on the case. And so please look this paper up. Again, I believe it's the November issue 2013 in the AJO. So the conclusion, again, is that undergoing orthodontic tooth movement, their orthodontic forces elicit inflammation. You get an expression of cytokines. There's bone remodeling that occurs, and then you get tooth movement. Now, with osteo-perforations, you get an increase in inflammation and cytokines, increase in bone remodeling, and an increase in tooth movement as the net effect. And so the science makes sense. Now, when it comes to the science of this latest and greatest technology out there, which is, in my opinion, not meant to replace MOPS necessarily, but to be used as another tool in your toolbox to help enhance therapy for your patients. And as mentioned, I use it sometimes on its own, as you will see, sometimes in tandem with osteo-perforations. And so the peer-reviewed science on high-frequency vibration are as such. So I'm going to present to you 4 papers here. And this is from the Journal of Musculoskeletal and Neuronal Interactions. And the question they pose, or the title of this, is bone formation induced by high-frequency mechanical signals modulated by muscle activity? And the key conclusions, and again, please go through and look this up, or you're going to have my email at the end of this. I'd be happy to email you the papers as well. But the key conclusion is that bone can differentiate between various frequencies of vibrations in terms of its ability to remodel. The subjects in this study were exposed to high-frequency vibrations, meaning above 90 hertz. And in this group, above 90, as opposed to low-frequency vibration, but high-frequency vibration above 90, bone formation rates at about a rate of 159% greater than the controls. Bone formation rates in low-frequency vibration, 45 hertz, were not statistically different than the controls. The structural benefits that bone can gain through exposure to vibration are indeed apparent. Now, the next study from the Journal of Dental Research from Dr. Alicani, osteogenic effects of high-frequency acceleration on alveolar bone. This experimental group had significant increases in bone quality over the same period compared to the sham or the controlled groups. There was an increase in bone remodeling activity resulting in thicker and denser bone trabeculae. Localized high-frequency force of low magnitude is able to indeed induce osteogenic activity within the surrounding bone. And you can see some of the histological slides here where there's signaling, and on the left side these are the control. On the right side is high-frequency vibration. You can see the signaling of bone activity when high-frequency vibration is applied. And high-frequency vibration caused nearly twice as much bone remodeling as low-frequency vibration, only at 5 minutes per day per application. That's astounding. Third paper from the Angle Orthodontist. So these are like, high research-based publications that are well received and well respected in our industry. And vibratory stimulation increase in interleukin secretion during orthodontic tooth movement. This is one of those secondary messengers that I was just discussing a few minutes ago about MOPS. Now we're talking about its release and its increase in release in using high-frequency vibration. and 15 subjects underwent bilateral extraction of first premolars, and canine retraction was performed and vibrated at a frequency of 125 hertz with an electronic toothbrush, and the experimental teeth moved 61% faster compared to the control side over not a 1, not a 2, but a 3-month period. That is profound. And so here's some of the graphing on the right side where you can see the statistically significant changes in these values. And after just 2 months of vibration, the secretion of interleukin 1 beta jumped to approximately 3 times higher than levels observed in the first time frame, month 1 and month 2. That is fantastic research. In combination with orthodontic forces, high-frequency vibration stimulation appeared to increase bone resorption activity, accelerated tooth movement, and greatly enhance the secretion of inflammatory markers in the gingival curvicular fluid, just like we witnessed a few moments ago from the paper in 2013. The final paper on high-frequency vibration showed the effects of high-frequency acceleration as a potential therapeutic tool to preserve bone following extraction of a tooth. And so the key conclusions here, the takeaways, are high-frequency vibrations accelerates bone healing in tooth extraction site. And so on the side here you can see where you've got static, meaning no vibration, and then high-frequency vibration. And what you can appreciate is the amount of bone in the extraction site and how much it's preserved over a period of 56 days. And that is fantastic news for potentially retention or maybe even just, again, preserving bone long-term for your patients. And so high-frequency acceleration vibration has an increase in bone healing through intramembranous ossification. So now there are different modalities. So I just went through the science of both micro-osteo-perforations and high-frequency pulsatile or high-frequency vibration forces, again, above 120 hertz. And so there are different modalities when it comes to accelerated orthodontic treatment. Now these first two are patient-controlled, and there are devices on the marketplace where there is low-frequency vibration. And research regarding this are ample in the on the internet, so you can look this up yourself and see the research that was done here. But these are to be used for 20 minutes a day, which might be something to consider when recommending it for your patients. The aligners potentially need to be removed. It's rechargeable. This started out much more expensive, and it's down to about $1,000 now in the marketplace. And there are some other low-frequency devices out there as well. Now, the other patient control is high-frequency vibration, and this has been used and is indicated to be used for aligner seating. Aligners must remain in the mouth during the treatments. It's rechargeable. It's to be used for only 5 minutes a day, which is what some of the research I just referenced refers to. And so you can consider this juxtaposed to the low frequency 5 minutes versus 20 minutes and what your patients might better tolerate. I know I certainly did that. And cost-wise, this is, I think, much more amenable and acceptable to patients. The retail price is around $400. As with anything, if you buy it in volume, you can, I believe, get some sort of price reduction. And again, this relies on patient compliance. Doctor-controlled techniques are corticotomies, where you raise a full-thickness flap. These are invasive. They are time-intensive. It requires a fair amount of recovery from the patients. There's several thousands of dollars of cost to the patient, and you must find a willing clinician that has extra training, whether it's an oral surgeon or a periodontist. There is piezo surgery, which can be done with or without a flap. It is less invasive than its neighbor next door here, the full thickness flap corticotomies. And again, it can be done with or without a flap. There's still a cost to it. Requires, again, extensive training from the surgeon. And depending on the alignment of the teeth, you may not have great access in between the roots. And then on the right here, there is manual osteo-perforations, which has been termed as micro-invasive. There's no patient compliance needed. Very minimal cost to the practitioner, which we'll go through in a moment, and very minimal training. This is very simple to do. So with manual osteo-perforations, I've chosen to use the Propel suite of devices. There's a single use, there's a reusable handle where this handle is autoclavable, and now there is a power driver. So I've used all three of these. I have them all in my office. I think this here is great for training, as is this one here. But once you get up to speed, the power driver is certainly the way to go. It's got a nice contra angle where these are straight. These have some depth limit, depth indicators, which help guide you as you are learning, which has been helpful and allowed me to use the power driver very easily. So we can go through each one. But in terms of the benefits of manual osteo-perforations, for the patient, it's minimally invasive. It's done chairside in minutes by the technician. There's no downtime. There's no recovery. It can be used with either aligners or braces. They can go back to work right afterwards. It's doctor controlled. It's not reliant upon patient cooperation or compliance. It saves time in that there are fewer visits to the office. That means less time away from school, etc. For your practice benefit, as I've already alluded to, it's a great way for me to make myself appear as if I'm a standout in my area and providing the cutting-edge technology. I've had patients come in and accepting treatment simply because I can tell them it's going to take a significantly less amount of time. And I'm doing a lot of external advertising on the radio, which has attracted many patients discussing aligner therapy and osteo-perforations to facilitate tooth movement. And then, of course, you can certainly incorporate a treatment premium, a fee, if you would like to. And also less patients burning out, asking when their treatment are going to be done. So three easy steps, very similar to TADS, where you certainly want to evaluate the treatment area through radiographic and clinical examination. Have the patient use chlorhexidine for a minute, once before and once after, and then you want to anesthetize the area. So there are different ways to anesthetize. I'm going to show you a video momentarily with topical. I use both topical as well as local infiltrative anesthesia. In my experience, where I've come down to now is where I used to do 3, 4, or 5 per case. Now I'm doing it once every 12, maybe 14 weeks, and I do 1 perforation, maybe 2, but typically now 1, and then I use Propel's V-Pro 5 because that is currently the one in the marketplace that has high frequency vibration. I typically do 2 perforations per site. 3 is recommended if you're doing 1 or 2 teeth. If you're doing a whole quadrant, you may want to consider doing, maybe just 2. But if you're doing 1 or 2 teeth, 2 or 3 is a must. As I mentioned, you get this nice radiating effect, and it perforates around where it is done, and you can use it again in a rate-limiting tooth or a stubborn tooth, which you will see. And in the anterior, you figure around 3 millimeters of depth. In the posterior, I figure around 7. And in between, in the bicuspid area, you figure around 5 or so. Osteoclastic effects take peaks in 24 hours and remains elevated again for about 10 to 12 weeks. And so as such, you can repeat it accordingly as you deemed necessary. But it is the simplest approach. There's no flap, there's no sutures, there's no recovery. It can be done on the buccal or the palatal on the palate. And again, as a guide here, there is a little atlas here where you want to figure about 3 in the front, 5 in the buccal, And if you're dealing with a stubborn second molar, then maybe you go a little bit about 6 or 7 millimeters. And again, 2 to 3 perforations per site. It can be done in a line, it can be done in a triangle, whatever you would like. But here's actually going on, and here's immediately following. So you can appreciate there is no bleeding, excessive bleeding that's occurring. I show my patients this, and they really no longer are concerned. Here's immediately after. This is actually my patient, and here is about 30 minutes after. So by this time they're driving back to their office or to their errands, and nobody knows that I had it done. And so here's a patient, and again, some of the topicals I use is the baddest topical in town, and this is from Woodland Hills Pharmacy. This is not an endorsement of Woodland Hills. This is simply one area where you might get it from a compounding pharmacy. But you can see that the perforations are very simple. This is with the device that has a light on it. I was having a training day for some doctors, and you just go in and do it, a little bit of pressure, and it just goes right in, and you can see the patient is not flinching, and he is alive despite what it looks like, and he is has enjoyed facilitated tooth movement. And you just kind of back it out when you're done, and that's it. So again, this is the manual. The power driver is a very much different experience. And again, you've got the single use, and the single use has a nice light if you're trying to train. And this one has a reusable handle, which you can autoclave the handle and dispose of the tips. And once you engage, and the nice thing about the disposable, if you're training, is you can dial in your depth, 3, 5, 7 millimeters, etc. The reusable handle, you've got depth guides that help you. And so the power driver has a nice contra angle, and you can has 2 modes where you press and hold the start button, and if you hold it for more than 3 seconds, when you let it go, the driver will stop. The other mode, if you press and let go, it'll keep going until you press it again. So doctors can decide which mode that they like. You can dial in the speed and the torque that you want, and it's got a forward and a reverse as well. And so it's very important for your patients when doing osteoperforations that you instruct them to only take Tylenol for any discomfort, because if you take Advil or aspirin or any other non-steroidal anti-inflammatories, you will negate the inflammatory response you're trying to stimulate to render the 4th order of orthodontics and augment the biology to your advantage. So profitability per visit example. Let's say you have an average case that takes about 18 months and the treatment fee is $5,500. The cost per bonding, etc., your hard costs are about $1,200, leaving you with a $4,300 net. So based on your frequency and the number of visits, if you see that patient every 4 weeks, that's 20 appointments to complete the case, that's $250 per visit profitability. If you see that patient every 8 weeks, you have 11 appointments, that's a profitability per visit of $425. If you see them every 12 weeks with just 7 appointments, your profitability per visit jumps to $615. So you can see that seeing a patient just 4 more times, okay, jumping from 7 appointments up to 11, can make a huge difference in your profitability for the case in the range of $750 to $800. So let's make another assumption. Let's say 20% of your cases in your office are past their estimated finish dates, their treatment time. So if you start 200 cases a year, that's 40 active cases that are over your treatment time. If you use the assumption I just had on the other slide, that simply 4 additional appointments for these 40 patients that are represent 20% of your cases over the treatment time, that represents 40 patients times $750. That represents a $31,000 monthly scheduling inefficiencies that affects the bottom profit line. Notice I didn't say you're losing money. I'm talking about scheduling inefficiencies because you're having to see these patients more, and they're clogging up your schedule. You could be doing much more productive things, like my good friend Dr. Thomas Shipley, proactively using Propel osteo-perforations with the liner therapy, and what he noticed is that with a $6,000 investment for, I believe it's a 48 pack of tips, you're able to do 1 to 2 perforations per patient, and that means that you can affect, for those 48 tips, you can affect 25 to 35 patients in your practice. That potentially means 25 to 35 fewer patient visits each month, which means 6 to 9 fewer visits every week. That means you're freeing up 30 to 45 minutes of chair time each and every afternoon. That is profound. What does that also mean? It means that there is almost an immediate impact and a positive return on investment for very minimal investment. The point is, if you're going to spend $6,000 for only 6 devices that might only affect 6 patients, why not take that same $6,000 for 48 tips and affect 25 to 35 patients for that same investment? And so I think that's fantastic. And now, you know, if you remember from geometry class, there are postulates, and postulates are also known as axioms, and an axiom is a statement that is accepted as true without proof. And so while Euclid had his postulates of geometry, I have my postulates of micro osteoperforations, and that being that the first postulate is that when you incorporate MOPS into any treatment plan, the corresponding decrease in the number of visits to complete the case is congruent with an increase in profitability per visit. If there is a space, postulate number 2, if there is a space that exists between 2 teeth, then there exists one MOP procedure that will close the space faster than conversely without doing MOPS. Postulate 3, in a single office visit with a nominal increase in chair time of no more than 15 minutes in all 4 quadrants will substitute for a savings of 2 to 3 visits to produce the same exact movements. Postulate 4, the 4th order of orthodontics is elicited with MOPS, allowing doctors to augment the host tissue's response to your advantage preceding force application. That's huge. We're able to augment biology with the 4th order of orthodontics preceding, before we apply our force application. Postulate 5, doctor-controlled and targeted specific ability are characteristics that are imitable to MOPS procedures. And finally, postulate 6, if X is a variable, then one's investment of X thousands of dollars in MOPS will translate into affecting 4 to 5.5 times the same number of patients, X number of patients, versus affecting 1 times the number of same patients for other devices currently in the marketplace. And in terms of topical anesthesia, you can use these compounding topicals. I will play a video for you, and it has some instruction as well. So listen in. Hello, my name is Dr. Jonathan Nicozisis, and I will be showing you how to use a topical anesthetic before performing Propel to ensure your patient's comfort. After receiving your patient's written consent, have your patient rinse twice with chlorhexidine for the duration of 1 minute each time. Be sure to dry the gingival tissue where the anesthetic will be applied thoroughly and where you plan to apply Propel. There are 2 approaches for applying the topical anesthetic. The first approach is to use a disposable plastic needleless syringe and directly apply the anesthetic to the tissue. Alternatively, some have spread it onto a piece of gauze and use the gauze to place the anesthetic onto the tissue directly. To ensure the patient's comfort, anesthetize the entire treatment area where Propel will be applied. With experience, you should be able to anesthetize multiple quadrants at a time. Leave the gel on the gingival tissue for 4 minutes. After 4 minutes, suction and rinse the gel off completely. Set a timer for 10 minutes to allow the anesthetic to penetrate the tissue thoroughly. After 10 minutes, use an explorer to ensure the area is numb. Once you have assured the area is numb and the patient is comfortable, you can proceed with the micro osteo-perforations using Propel. Here are the formulas for 2 separate topical anesthetics recommended for use with Propel. It is important to note that with any topical anesthetic, the patient will still feel pressure but should not feel any pain. If the patient experiences any pain while testing the area with the Explorer, begin the topical anesthetic application process again. For more information on how to Propel, please see my step-by-step video tutorial on how to create micro osteo-perforations using the Propel drivers. And now I'm going to show you a video on the power driver. Hello, my name is Dr. Jonathan Nicozisis, and I will be showing you how to perform micro osteo-perforations using the Excellerator PT, or power tip. Evaluate the treatment area on the patient. Track the roots, the mandibular nerve, and maxillary sinuses. Have patient rinse twice with chlorhexidine for the duration of 1 minute each. Anesthetize and Propel with the Excellerator PT. To ensure the patient's comfort, anesthetize the treatment area using either a topical or local infiltrative anesthetic. Once you have assured that the treatment area is anesthetized, secure the PT tip into the contra angle. To assemble the Orthonia driver, please reference the manufacturer's manual. Before inserting the Excellerator PT, ensure the driver has been fully charged. Then open and rotate the latch on the back of the contra angle about 30 degrees, and insert the blue side of the PT first into the contra angle head. Rotate the tip until you feel it seat and close the latch. To ensure the tip is fully seated, observe the back of the contra angle. If the tip is correctly attached, it should look fully flush. Micro osteo-perforation depths are determined by bone and soft tissue thickness. Micro osteo-perforations should penetrate through the cortical plate into cancellous bone. Once the PT tip is secured in the contra angle, turn the driver on by pressing the power button. The next step is to select the torque using the torque button on the driver. The ideal torque setting for micro osteo-perforations is 30 Newton. Next, use the RPM button to select the speed of the driver. The recommended speed setting for the micro osteo-perforations is high. The higher speed and torque settings for this Orthonia driver are uniquely ideal for micro osteo-perforation. As the final step before beginning micro-osteo-perforation, ensure the reverse indicator is off. The power driver has two modes, temporary and general mode. You can use either mode for micro-osteo-perforation. In the temporary mode, you can hold down the start-stop button and the power driver will continue the rotation until the button is released. In the general mode, you must press the start-stop button briefly to start the rotation and then press it again to stop the rotation. To begin micro-osteo-perforation, place the driver so the tip is perpendicular to the treatment area with the driver display facing you. Press the start-stop button to start the rotation and apply gentle pressure to engage the tip into the attached gingiva. Press the start-stop button again to stop the rotation. With experience, you can easily and intuitively know when you have reached the desired perforation depth by recognizing subtle changes in the driver, such as hearing the motor change cadence and feeling the speed increase once you have perforated the cortical plate. To remove the PT tip, change the direction by pressing the counterclockwise button until the reverse indicator light comes on. Then start the rotation until the PT tip disengages from the attached gingiva. At the completion of the treatment, remove the single-use power tip and dispose of it appropriately. Be sure to power off and charge the driver for your next use. Where possible, perform 2 to 3 micro-osteo-perforations on attached gingiva in a linear fashion or triangular fashion. In the interest of time, I will continue. High-frequency vibrations, again, are to be used for 5 minutes a day. You have an oscillator, a mouthpiece, and a wall adapter to charge it up. You can go over instructions with your patients on how to use it, the different lights, what they're indicated, etc. This is all in the packaging. And then you can even hook up your patient's ID to each device, so when they can come in, you can hook it up to the software and you can track their usage so that they know that they're being watched. So for more additional resources in Catapult, you can go to this website. So when it comes to cases, I've got about 14 minutes to go. Here's an adult. You saw David already, where I was able to treat him in 7.5 months. And I went through the why this is impactful. Now, here we have an adult female. I treated her in 12 months using 2 osteo-perforations. She's subdivision class 2. The beauty of osteo-perforations is that I can target exactly where I want this. We've got, to facilitate the movement, we've got super eruption on the upper right quadrant. And so we're class 1 on the left side. So I'm doing no Propel on the left, only Propel on the upper and lower anterior and upper and lower right side here. And so when you look at her ClinCheck, you can see how I'm doing no distalization here. My movies are not playing. I apologize. But suffice it to say, I intruded this upper right side, and we got to 11.5 months of treatment right before her wedding, and I went from, this is 7.5 months, but I went from a 90% class 2 to about a 20% class 2, just helping augment the alveolar bone. You can see the improvement in the smile line as well as the intrusion to help even out my gingival display. And again, here we are done right before her wedding at about 11 months. No distalization there, just intrusion. You can see the improvement of the gum line. Here we have another adult patient. Total treatment time, I told him originally about 14 months. I had to do perforations. I got done in under 6 months. And again, I targeted the perforations in the upper and lower anterior and just the lower right side using class 3 elastics with the liners. And you can see that we got done in 5.5 months of total treatment, 22 weeks. and 6 months in retention. He's now about 2 years in retention and looks exactly the same. So like David, with this patient, same exact fee, but I actually saw him 1 visit less. And you can see how my profitability per visit jumped. David's was $1,120, and Alan's here is about $1,400 profitability per visit. Class 3 anterior open bite, 6.5 months using 2 Propel procedures. This would be surgery back in the day. High mandibular plane angle. No TADs were used here. I simply intruded the posterior teeth using Meow Mechanics multi-loop edgewise arch wire, and I extrude the upper and lower anterior teeth. Class 3 elastics, as you can see right here, and we get to 11 months, 2 Propel procedures, and I scan for refinement. We get to 16 months. I throw on some rubber bands to do some settling here, and we are done at 17.5 months. Naturally, you would like to see the Ceph, which is before and after, and then of course we've got 6 months and 1 year of retention. Here we have a very narrow arch form. SARPI was indicated. I completely agree with that. She did not want to go through a SARPI, and so I was able to propel her and get her to refinement in 22 stages in 5.5 months, and now I'm settling the case. But look at that arch form change, and look at the alignment of 8 and 9. I hate putting braces on those teeth. And then we settle the case and we're done in 7.5 months. Not perfect by any stretch of the means, but here we are, 6 months of retention and a year in retention just to show the stability of the result. Here we have crowding. This is a hygienist. Look at this lower right, oops, sorry, look at this lower right 5. Look at the rotations there. And I got done in 5 months to refinement, and refinement was just tightening up a few light contacts. But to go from there to there in 5 months with 2 Propel procedures, look at that rotation of that 5. That's insane. Next case, adult posterior crossbite. Original treatment time would be closer to 2 years. I got done in 12 months with 4 perforation procedures. Aligners only, no crossbite elastics. I used class 2 elastics in refinement to get my midlines coincident. And here we are at 6 months refinement, class 2 elastics on the right side, and we are done in 12 months. That's impactful. Four perforation procedures, and we are looking fantastic. 12 months in retention. Everything's looking great. Here we have braces. Here's an adult. Original treatment time was over 2 years. Estimated I got done in 18 months. I took out upper 4s, lower right 4, lower left 5. Class 2 skeletal. I'm not a Damon person, but this is my first Damon case using Insignia. What you're going to see is 5 months worth of alignment. I then did perforations. This is my first Propel case. I did perforations upper anterior, lower anterior, and the lower left 6 and 7 to protract those teeth. And after 3 applications of Propel, 7 months of actual Propel treatment, 12 months of total treatment, because you remember the first 5 months were just alignment. I said we can stop propelling, but to go from there to there in 7 months with 3 procedures is absolutely fantastic. Likewise on the lower, to go from here to here in 7 months, from month 5 to month 12 of treatment. And from month 13 and 14, I did not do Propel, and I could not close this darn space. And at month 16, I said we need to go back in and do Propel right here. So at month 16 and 17, I did 2 Propel treatments, and I closed that space to get them finished up. Had I not taken that hiatus, I probably could have shaved another 2 or 3 months off of this case. And here's a before and after pan, right at the time of debond. Again, he's class 2 skeletal. I'm not a Damon person, but nice improvement in the profile. Next case, estimate treatment to be about 24 months, and I used 5 perforations procedures to get done in 16 months because he had a missing number 10. I sectioned the bridge and swing the whole midline over to open up an implant right here. And so to get all that done in 16 months, I think is astounding. I'm just going to jump right to the end here. Sent in 16 months to the prosthodontist to evaluate the space. They said that that space was fine. They put an implant in, band removal, you can see the implant, and then we are done. So 16 months to swing the midline over and open up the space. That is profound. So now let's go to cases using aligners and high-frequency vibration. Class 2, high-angle, excessive overjet. Again, this case there are no MOPs. This is a Class 2 TMJ discomfort, and she got her wisdom teeth removed. But look at this Class 2. Watch the airway here. And I'm going to show you my ClinCheck. Now, in the advent of aligners weekly changes, I think that has zero impact on Propel and high-frequency vibration, because ultimately the fourth order of orthodontics is only elicited with Propel. It is the only product on the market with MOPs and high-frequency vibration that will augment the biology preceding our force application to our benefit. And so when it comes to aligner seating, I would bet my house that when you look at this mechanics here, look at how I intrude these posterior teeth, there is no way that 1 week aligner switches would fit properly on their own without the aid of a proper aligner seating tool like vPro 5, which is what I choose to use because it's the only one that elicits high-frequency vibration at this point in time. But there's no way weekly aligner changes. I have 20 aligners, okay? And you're going to see here that I start Class 2 elastics. We're going to rotate the mandible forward. 12 weeks. Look how well the aligners are fitting, even on those pesky laterals. And here I am, 20 weeks and 20 stages, 5 months of treatment. Look how well those aligners are fitting. You saw the amount of intrusion on the ClinCheck. There is no way on God's green earth that those would fit properly with weekly aligner switches without an aligner seater to aid in seating the aligners. And so at 5 months, I took impressions for a scan for refinement. Here is my Ceph. Look at the difference in the airway. The rotation of the mandible forward. I'm entering the posterior teeth using meow mechanics. At this stage, I IPR'd the lower anterior to retract the teeth to get better overjet. The patient reports a remarked improvement